Welcome, everyone. Thank you all so much for joining us this evening for Black Health Conversations. You could have been spending your day doing anything else, and we're just so grateful that you're here with us. My name is Marcilla Ryan Harris, one of the co-founders of Black Health and tonight's moderator. Before we get started, just want to go over a few house rules. Use your chat function to engage with us. If you've never been to a Black Health event before, you have to know we love engaging with our audience, and we want it to be an engaging learning experience for everyone. So feel free to ask any questions and post your comments throughout the session. Most importantly, this is a safe space. If you don't understand a word or a concept, please ask for clarification in the chat. Also be mindful and have compassion and respectful as we will be discussing sensitive topics throughout this session that can affect different people in different ways. And remember, it is perfectly okay to step away at any point if the conversation gets too heavy for you. So now that we've gotten the rules out of the way, Black Health is an Atlanta-based nonprofit organization started by 4 friends who met in graduate school. My partners, Khadijah Amin, Matthew McCurdy, and Paula Wheeler. We engage the public and health professionals on the impact of racism on Black people and then equip them to do something about it. We envision a world where racism and other intersecting forms of oppression do not determine a person's ability to achieve optimal health. And tonight's event is a part of our amazing partnership with Cottonelle, the Good Down There campaign. We are working together to provide education and awareness, complimentary screenings with the assistance of our amazing community ambassador organizations, So Others May Eat in Washington, D.C., Trap Medicine in Oakland and Los Angeles, California, Change Happens in Houston, Texas, Neighborhood Service Organization in Detroit, and Babashi Transition to Hope in Philadelphia. We're also providing financial resources to Black people in partnership with the Colorectal Cancer Alliance to help decrease barriers to care, increase access to needed resources, and reduce the stigma around colorectal cancer. To date, we have distributed over 5,000 colorectal cancer screening kits via online and grassroots efforts to 49 states. We are only missing Alaska, so if anyone out there tonight knows anyone in Alaska, plug us in because we need to get these screening kits to people in Alaska. We have also impacted more than 50,000 lives through our educational efforts via web-based events like this one we're hosting tonight, our social media, our wonderful ambassador organizations, media outlets, and Walmart wellness trucks. And one of our key partnerships, as mentioned before, for those of people in need of additional medical attention, Black Health and Cottonelle have established a $300,000 financial assistance fund in partnership with the Colorectal Cancer Alliance to provide resources and free colonoscopies to Black people in need. And to date, we have had over 40 individuals submit for colonoscopy support. So tonight's event is the second event in our series of health education events, part of our Good Down There campaign. Our learning objectives for tonight are to raise awareness and increase knowledge of the impact of racism on colorectal health outcomes, build community among Black people who are living with inflammatory bowel disease or IBD and other comorbid conditions, and brainstorm and discuss culturally responsive interventions for the protection of Black people's health. Now, to get started, just a few quick statistics. Black Americans are 20% more likely to be diagnosed with the disease and have a 40% higher death rate compared to white Americans. And Black Americans are also more likely to be diagnosed with colorectal cancer at an earlier age and with more advanced disease than non-Hispanic white Americans. So that is why we are really pushing to raise awareness and increase screening rates among Black Americans. Because if this disease is detected early enough, there is a 90% survival rate. So just a quick background information about colorectal cancer and comorbidities. So colorectal cancer is the third most common cancer in the United States and the second most common cause of cancer-related death. It is estimated that 149,000 people will be diagnosed with colorectal cancer in 2021. So what is colorectal cancer? We keep saying it, but what is it? Well, colorectal cancer is a cancer that starts in the colon or your rectum. These cancers can also be called colon cancer or rectal cancer, depending on where they start. Colon cancer and rectal cancer are often grouped together because they have many features in common, such as symptoms, risk factors, incidence, and genetic makeup. But the greatest difference between the two cancers lay in the anatomy of the body and gastrointestinal tract. While the colon and the rectum are both part of the large intestine, the colon is approximately 5 feet long, while the rectum is the last 5 to 6 inches that connects to the anus. And if you look here at this Venn diagram, you see the things that both these cancers have in common and what also makes them different. So colon cancer is equally common in both genders. It has easier surgical treatment, and radiation is not commonly used for treatment. However, in rectal cancer, it is more common in men, metastasizes more easily, which means it spreads, and is more difficult to cure. The signs and symptoms that you want to be on the lookout for: change in bowel habits, so that's diarrhea, constipation, or any abdominal discomfort, rectal bleeding, feeling overall weak and fatigued, or any unexplained weight loss. If you're experiencing any of these signs or symptoms, you will want to get screened immediately. So what are the risk factors? A risk factor is anything that raises your chance of getting a disease such as colorectal cancer. And with colorectal cancer, some common risk factors are age. We see that people 45 and up, we see that there's an increase of diagnoses. If there is a family history or a personal history of polyps, past diagnosis or family history of colorectal cancer, inflammatory bowel disease, including ulcerative colitis or Crohn's disease and other comorbid conditions, lifestyle factors such as your diet, level of physical activity, smoking, and alcohol use. So what are comorbidities? A comorbidity is the presence of 2 or more conditions occurring in a person either at the same time or successively, meaning that one condition occurs right after the other. And when it comes to colorectal cancer, certain comorbidities may increase the risk for developing colorectal cancer, and if diagnosed, may complicate the treatment and management of the disease. So that just means that if you already have a certain chronic condition, it may either increase your risk for developing colorectal cancer, or if you are unfortunately diagnosed with colorectal cancer, it limits your options. So when should you get screened for colorectal cancer? The official guidelines state that if you have no family history of colorectal cancer, you will want to start getting screened at the age of 45. If you have a family history with a first-degree family member, so that is one of your parents, a sibling, you will want to get screened at age 40 or 10 years younger than the age that family member was diagnosed. So if your father was diagnosed with colorectal cancer at 50, then you will want to get screened at 40. And then if you also have a history of 2 or more first-degree family members with colorectal cancer diagnosed at any age. Again, that will start at age 40 or 10 years younger than the age at which that family member was diagnosed. So that was a really quick overview, guys, of colorectal cancer and comorbidities. Our first event, we really delved into more information about colorectal cancer. So if you haven't checked it out, please check out our website to watch that previous conversation just to get more information. And now, to start for tonight's conversation, I'm really excited to bring in our panelists. We have some really awesome guests joining us today. Up first is Melodie Narain-Blackwell. A serial entrepreneur and health advocate, Melodie is passionate about patients and families who have had to navigate healthcare without direction or support. Diagnosed with Crohn's disease in 2018 after battling digestive issues for over 20 years, Melodie stands boldly against health inequity and policies that support such. Melodie is the founder and president of Color of Crohn's and Chronic Illness, Inc., a nonprofit organization that has the mission to advance the quality of life of BIPOC patients who are facing gastrointestinal disorders and other debilitating illnesses. Melodie, please join us on the stage today. It's so great to have you here this evening.
Thank you so much, Marcella. I am happy to be here. Hello, everyone.
Thank you. And finally, our second guest, Justin Smith. Justin is the director of the Campaign to End AIDS at Positive Impact Health Centers, where he works with community to develop and implement strategies to bring about an end to the HIV epidemic in Metro Atlanta. For the last 20 years, Justin has worked in a variety of capacities in HIV research and practice, focusing primarily on improving our understanding of the social determinants of HIV among marginalized communities in the United States, particularly among Black, gay, and bisexual men. Welcome, Justin. So great to have you.
So glad to be here. Thanks so much. I'm really happy to be here tonight.
Thank you. So jumping into the conversation, it's going to be great. I'm very excited, guys. So Melodie, can you just tell the audience a little bit about what IBD is and what signs and symptoms are associated?
Absolutely. So IBD is inflammatory bowel disease, which is mainly characterized by two diseases. That is ulcerative colitis and then Crohn's disease. Basically, it is chronic inflammation of the gastrointestinal tract, which starts in the oral cavity all the way down to the rectum. The challenge with inflammatory bowel disease, though, is while it may affect things in your colon, it is a chronic disease and it's an autoimmune disease, which means that while the presentation may seem like it's only internal, and most people think that, hey, it's an inflammatory bowel disease, that means I have a problem pooping. Like I either go too much or I can't go. But here's the kicker. Because it is an autoimmune disease, the inflammation can go anywhere from your inflammation in your eyelids to mouth ulcers, to knee pains, to arthritis, to challenges outside of just arthritis, but with your joints and your movements. And so it's not just isolated, but these are called EIMs, which are extraintestinal manifestations. So once your disease gets to a certain place, it causes fatigue. It causes other comorbidities outside of just the inflammation and chronic, but psoriatic arthritis or other things. So it's important to get properly diagnosed, but understand that sometimes we experience all these things and less stomach aches, and we don't realize that it is directly related to that particular disease. Some of the symptoms with IBD, as I named, are extraintestinal. But for me, I lost my hair, I lost my mobility. I had a very interesting extraintestinal manifestation called fistula, which are like extra tunnels from my colon. So you have your colon where you excrete your waste, and then here I come with like 4 more colons, exits coming out. I call them little tunnels because it's like an abscess from the infection. It bursts and it has to go somewhere. So I experienced a challenge where I actually had drains in my colon. And the challenge with IBD and colorectal cancer is that there are a lot of the presentations that look very similar, including the challenge with bowel function and also ribbon-like stool, the constipation, the diarrhea, the blood in your stool. So it's very important that when you're experiencing any of these kind of challenges, it is a clear sign that you do not stop at stop. You pass go, you don't collect $200, but you get to the doctor.
Yes, absolutely. Thank you so much for sharing that, Melodie, because I think, as you said, like a lot of these symptoms look like different things, and it's hard for people to kind of like advocate for themselves if they don't really understand what's happening to their body.
Absolutely. And as a community, we are so prone to ginger ale as medication.
Yes.
And so when we get these stomach aches, and that's a symptom I didn't mention as just like one of the larger symptoms, but it's the one that we often pacify or ignore, and we feed it with ginger ale and crackers. And that is totally not the answer.
Right, exactly. It was a good way to get out of school when we were kids, but not so much as adults. And so you shared a bit about your personal journey. So could you just talk a little bit more about how that led you to start the Color of Crohn's and Chronic Illnesses?
Sure. I remember as far back, I am about 40 years old. So I remember when I was about 6 or 7 years old, I did have chronic stomach aches. eggs. And I'm multi-ethnic. My father is Indian and my mom is Black. And either I had ginger and some kind of bread on my dad's side, or I had ginger ale and crackers on my mom's side. And that's how we managed it initially. And as I got older, around 8 years old, I knew that my stomach aches were getting a little bit more aggressive. And we still kind of just managed it. And, we didn't know, because this is not something that's talked about in Black community. You don't hear IBD, you don't hear Crohn's disease. You might hear colitis, but you don't necessarily hear ulcerative colitis. And I'm talking all these years ago, over 30 years ago, when we're dealing with this. What we knew in the Black and brown communities, I would say more so high blood pressure, diabetes, high cholesterol. Those are the things that kind of resonated with the community as a more aware types of diseases. And we managed it that way until I was about 12 or 13 years old, and I started having bleeding out of my rectum. And I wasn't sure what it was. And naturally, children, what we don't know is that children don't just have like hemorrhoids. There has to be some kind of trauma or something that happens to the rectum. It doesn't just happen. And I finally told my mom after about a month, because it would like happen and it would be a little bit, then it would go away and then it would happen again. And I'm saying, I don't really think this is normal. This is not red peppers, not tomatoes, not tomato sauce. So I need to talk about this to my mom. And I did. And she did what a mom would do. She made the appointments, got me to a gastro. At that time, they did something that kind of caused trauma. And I didn't realize it until I was an adult that this experience caused trauma in my life. But I had a flexible sigmoidoscopy, about 2 feet, a flexible scope inserted into my rectum while I was awake. And my mom was there with me. She almost passed out. And I remember that experience and the pain that I was feeling and thinking, how could they put anybody through this? I'm a child, but even as adults, like you're awake with this procedure, it was crazy for me. And once we had that procedure, they told me I had internal hemorrhoids. They didn't think about the fact that I had been suffering with stomach aches for all this time. And stomach ache is not a symptom of internal hemorrhoids. But we don't know that. We didn't know that. We didn't have the knowledge. We took that information, and here began the journey of Metamucil, Tums, and Pepto-Bismol. And for 20 years, I managed my stomach aches that would come for sometimes months at a time, like weeks. So it would come for a couple of months, at least 1 week out of that month. And then it might stop for a month, and then it'll come back. And I just managed it for 20 plus years that way. And I would go to the doctors, and maybe it's IBS, or, it wouldn't happen at the time. So it would be hard to explain that this is what I was going through. And I managed it that way. Everyone knew I had stomach problems. They were prepared on trips. I would sleep in the bathtub because my body would feel so hot that the tub would be the only thing that could provide any kind of soothing or comfort as I was enduring this pain. And it would be bad. And I just became numb to it, and I got used to it until I had my son in 2013. And when I was going through my pregnancy, actually just before that, I had a tumor in my face. It was very weird. We didn't know what caused it. They said something was autoimmune. The next year, I give birth to my son, and I'm literally the nutty professor. Like, I would be having this conversation with you, and you're looking at me, and all of a sudden my lip would grow, and it would just go down to my chin. And people are looking at me, and they're like, and when they made that face, I said, oh, the lip thing. And they're like, because they would literally see my lip growing like I'm Buddy Love. And I would go to the hospital. They would say, what did you eat? Do you have an allergy? No, I don't have an allergy. Okay, she has an allergy. Give her Benadryl. They give me Benadryl. I'd have this great sleep. I wake up. You don't have an allergy. I know. Here's steroids. Still not getting to what is going on with me or diagnosis. I went to an ENT. He then told me to squeeze my lip. Just squeeze it when it happens like that so you can help the blood flow. And I said, this is got to be the most insane thing I've ever heard. And I did not squeeze my lip. My poor mother would constantly say, did you squeeze your lip today? How are you doing? Have you been squeezing your lip? And I'm like, listen here, Linda. I am not squeezing my lip because that is not what's going on with me. I then started eating all organically, and it helped to dissipate some of the symptoms. But the stomach aches and the bleeding, it actually started to increase. And then at this time, it increased for 4 months straight. I could not stop bleeding. I would shake when I used the bathroom and felt like Edward Scissorhand lived in my colon, like literally slicing down my insides. I would fill the tub with blood and I couldn't manage it anymore. I thought that I had been managing. I would sleep in the bathroom in the middle of the night, just sneak off. And my husband, every day I said, my stomach hurts. And he's like, okay, like he didn't understand, of course, because he's not educated on digestive diseases. And frankly, I knew of Crohn's disease, but never the way that mine had presented itself, because I had a family member with Crohn's disease and it was completely different. And one night, like he saw me in the bathroom and he sees the blood everywhere. And it's like, I couldn't shut that off anymore, because now he's been exposed to my secret of me trying to manage this challenge my own. And I started to lose my mobility. Like I was starting to get really bad cramps in my feet and swelling that it would look like a loaf of bread. One doctor said I had elephantitis. Another one said that I had gout. So I was getting all these crazy diagnoses, and me not believing anything and believing that anything that was going on with me, even though I wasn't educated at that point in this phase, I believed that it all had to do with my rectum. I just believed that so fervently and vehemently, like this is connected to my rectum. So I finally go to a doctor. I let him know I've had abscesses that are recurring. They're bursting. I'm sticking cotton in my rectum because it won't stop bleeding all day long. I'm having headaches. I feel like I have an infection. I'm like going through everything. And he's like, okay. He does the test. I mean, he does an exam and he says, I don't see anything. And I'm so baffled because I'm like, I'm telling you that I'm bleeding all day long. You got to see at least something. There's got to be something there. And he says, I see nothing, but I'll run some tests. And I left that office confused because I thought I was going in there to cancer. You know, we're going to think extreme because we don't know. So I'm like, okay, he's going to tell me I'm going home with Fred, Sanford, and Elizabeth because that's what's happening to me at this point. And for 3 weeks, I don't hear anything. And I wake up one morning and I felt a hammer on my head. I could barely keep my eyes open. My face is swollen. Everything is swollen. And I drive to work with my head kind of hung low. I get to the office and I'm sweating, like dripping sweat. And then I'm freezing. And you can see my hair's just sticking up. And every 15 minutes, that was the cycle. Sweat, freezing. And my boss at that time said, you need to go to a doctor. I finally drove to urgent care against my will. And I went there and she's doing chest x-rays because I have this weird cough that I call the Crohn's cough. And she's like, I don't see anything. And I said, okay, but can you do me a favor? Can you check my rectum? And she's like confused, like, girl, you have a cough and you have a fever, 102.3. Like it's nothing, not your butt. And I'm like, but it is. So she texts my rectum and she pushes back and she's like, oh my goodness, you need to call your doctor. You're bleeding from everywhere down there. Like your veins look like they've burst open and you have to call your doctor. I called the doctor, tell him I hadn't heard anything back about my test results. They said they didn't see anything, so they didn't think to call me. And I was thinking, if you didn't see anything, you still call. You still say, hey, we didn't see anything, but I recognize your concerns. Let me do some further investigation because I'm not an uninformed patient. I came with my list. I came very genuine and knowledgeable, and you just left me on the table. And so where was the bias there? Because it was clearly there somewhere. Because I didn't come uneducated. I didn't come with the wrong zip code. I didn't come with these things. So I should have naturally had better care, right? So I get to his office 3 days after that appointment. My temperature went 102.3, 103.8, 104.3 by the time I got to his office. I was not eating, and I had lost 7 pounds in 3 days. He goes in to do a rectal exam. I had a golf ball size abscess about right at the tip of my rectum. He goes to do the exam and then it bursts. And I could feel it. It was like fire shut up through the inside of my whole body. And he says, oh my goodness, you were right. You do have an infection and we have to get you into surgery in the morning. And that was my space to start the journey of finally getting diagnosed after 25 plus years with Crohn's disease. And that's how it began, with trauma, even though I came in a time that we probably could have avoided all of this. After that, as an entrepreneur, I owned a restaurant. I had a bridal shop at one point, serial entrepreneur. I still had a full-time job, but I always had a business. And I would share with my audience because I was a coach. And as I shared with them for the last 3 or 4 years, I talked about the priority of health because you can't build wealth if you're dead. So you got to shift this to health like it's supposed to be, then wealth. And I've shared all of my journey of where I'm going and doctors, and you keep going and trying to put this positive spin. And when I finally put, hey, I've been diagnosed, you've seen me with the knee brace and the 64 ounces of fluid removed from my knee. You've seen me with the ankle brace and the foot brace and the eye infection I've told you about. And like all of these things, I have an answer. It's Crohn's disease. And I got flooded with messages, and people were asking me so many questions, and they said that they were the first person diagnosed. And I was like, no, sweetie, you weren't, but we just didn't know about this disease. They had family members. Can you talk to my cousin? This person, like every person almost that I met that was a Black person of color, they thought they were the only person navigating this disease. And they had been somehow forwarded to me or exposed to me. And I said, well, Lord, what am I supposed to do? Because you're giving me this information. I know for profit. I'm not nonprofit. I'm like where the money resides. So I don't know what this goes. And so the Lord was like, I'm going to pave this way for you. And I had been working, I built a company that was completely out of the scope of what I do. And he said, that money is for this. So for the first 2 years, I funded Color of Crohn's and Chronic Illness. We started as a Facebook group for people to just get peer connections and support. But once you're exposed to such a huge disparity and it gets magnified with each passing day, you are not human if you don't try to do something about it. And I just had to do what the Lord placed me to do. And ever since then, we've been growing and we've been exposing and bringing awareness and shifting. And it's long overdue because these digestive diseases have impacted us so severely that we are even traumatized because of medical mistrust and unethical practices in healthcare that we don't even want to go anywhere. We are fine with dealing with the pain that comes with it because we know what that looks like.
Wow, Melodie. Well, one, I'm glad that you finally were able to get a diagnosis and you just really stayed on top of these doctors to know, like, no, you weren't accepting that nothing was wrong. So, like, kudos to you for continuing to push and push until you got an answer. And I know, you talked about medical mistrust, and we also know like stigma really plays a role into even these type of down there issues. People don't want to talk about that. And really, it just really affects how people access prevention and treatment services. So could you just talk a little bit about like, what are some things like as a community we can do to kind of get rid of that kind of stigma?
Sure. I think it's important to understand, one, things have changed. So a lot of times with complications for us in the Black community, because we are diagnosed at moderate to severe, our disease is really severe, which may mean bowel resection. It may mean having to get a ileostomy or colostomy bag. It may mean, like for me, urgency, where as soon as I eat, it just came through. So I confined myself to a house for months because I just was like, I'm going to use the bathroom on myself, and it's embarrassing. But I say that it's important to invite the conversation in. You don't know about something and someone is battling that, or they're challenged with this particular disease. We have to open up the community to have the conversation about it, like we're doing here. This is really important because what people don't realize either is that dealing with Crohn's disease at 20 years, you're at a risk for colorectal cancer. Just having Crohn's and ulcerative colitis, inflammatory bowel disease, you're at a risk for CRC. But then when you've had the disease for 30 years, you're up to a 20% risk of actually getting CRC. So you have to pay attention and know when these triggers are happening. But if no one talks about colorectal cancer, then they don't talk about inflammatory bowel disease, and then they don't talk about the intersection of both, then we don't have the foundation to say, hey, Justin, remember you said you were having that stomach ache. What did you ever do about it? Did you get to a gastro? I can refer you or I can go with you. Here's some leading questions for you so that it's more comfortable for you to have the questions answered by the doctor, but also know that I'm a resource for you. We are as strong as we are together. That's how strong we are. Yes. And the more we open up ourselves to be the catalyst for the foundations of change, we can shift. We don't need anything else but the space inside to provide people with comfort to have the conversations. That's the very beginning, but it's also the tree that can grow all the fruit that you can possibly think of.
Yes, I love that. I absolutely love that. And so, Justin, I know we're gonna shift a little bit, but I did want us to include HIV in the conversation because HIV is also, a comorbid condition we see with people with CRC. And so recently, we've seen stigma about HIV and AIDS front and center with the baby's ignorant comments that he made at the Rolling Loud Festival. And so could you just talk a little bit about how attitudes like the ones he expressed really impact HIV prevention and treatment?
Sure. And, thanks for that question. I think, like many people, when we first heard the baby's comments, it was really just like, oh my God, we're still in this space, really? But I think, we're also at a moment where we have incredibly powerful tools to combat HIV. So what people don't know is that there's actually a pill that prevents HIV. So pre-exposure prophylaxis, or PrEP. It's actually been around for about 10 years, but a lot of folks, particularly folks in the Black community, don't know about it, right? And I think that's a major travesty and something that we want to try to shift. But stigma really gets in the way of all of the tools that we have. We know that for folks who are living with HIV, stigma, decreases people's willingness to come into care once they're in care and to stay in care. And we know that's so vital for people to live long and healthy lives, to be connected to care. For people who don't have HIV, what the stigma does is it undermines people's willingness to even get tested to learn their HIV status in the first place, right? It prevents people from having the conversations with their partner so they can actually, take precautions and take the steps they need to protect themselves. It also, really undermines the ability for people to, have open and honest conversations about sex and sexuality. So in a sense, stigma really undermines the health of the entire community. And in many ways, because we have such great biomedical interventions to help folks who are living with HIV live long, healthy lives, and for folks who don't have HIV, we have powerful tools to actually prevent the acquisition of HIV. Stigma actually is one of the most challenging parts of the entire enterprise because, if you are on HIV medications consistently, you're connected to a provider team, you can live a long, healthy life, right? And so we can manage that with the medications that we have available. However, I can't do anything as a medical provider to deal with the stigma that a lot of the folks that we serve are facing in the broader community. And so I think that is really where a lot of our work remains. And I think the baby's comments really just brought that front and center to say that, oh, actually, we haven't really come that far, even though we've really increased our sort of biomedical acumen in how we address HIV. The stigma still persists. And I think that's where we have to really center a lot of our work. And I think, when you think about kind of what do we do about that, right? So I think there's several different things that we can do. I think from an individual standpoint, the first thing that folks need to do is actually learn their HIV status, right? So I think that's an action that everybody can take. The CDC recommends that pretty much anyone ages 13 to 64 should get an HIV test at least once in their lifetime. And if you're part of a community that is more vulnerable to HIV, that recommendation is that you get tested on a more frequent basis. But I think that everyone should learn their HIV status. So I think that's number one. Number two, I think that, like with the baby's comments, I think, I saw that as this really incredible opportunity to have a conversation, right? And I think, one of the things, I've been working in HIV for over 20 years at this point. And something that I've seen over time is that we have sort of less conversations in like school settings about HIV. It's not sort of part of popular discourse in the way that it once was. Like in the 90s when Magic Johnson disclosed his HIV status, that was such a watershed moment, particularly for the Black community. And we haven't had many of those moments. Like most recently, we had the actor Billy Porter come out about his HIV status. And I think we've had these kind of moments to sort of have this conversation. So I think, that's, one of the other things we can do is when we see these moments, these openings that say, no, the stigma is still here. Let's talk about that. So, and I think, interrupting, and I was really happy to see that so many people, there are a lot of people that were co-signing what the baby was saying, which is, unfortunate. But I was actually encouraged to see a lot of folks coming in and sort of calling him out and saying, you know what, actually, this isn't the right way to do this. And there were about 11 Black-led HIV organizations that actually sent the baby an open letter. He's not responded. But I think, it really goes beyond, kind of the conversation with him in particular. And the third thing that I would say is that something else that people also oftentimes don't know is that 37 states in these here United States have laws on the books that actually criminalize HIV transmission. And we know that that's something that, given that we're having this broader conversation in our society about criminal justice reform and, particularly the impact that the criminal justice system has on Black people in particular, this is just another, kind of instance of that. And I want us to be able to connect those dots a little bit more, because I think oftentimes, when we talk about HIV criminalization, it's really happening in this sort of HIV advocacy space, but really it's just part of the larger structure that criminalizes Black bodies, and we need to talk about it in that way. And we know that that's also something that intensifies the stigma that's associated with HIV. So we have to kind of do that structural sort of reform as well. So, just to kind of recap, individual level intervention, everybody get an HIV test. There's so many ways that we can do that. We'll drop some links in the chat that can provide some information about that later on. Number two, sort of have that broader conversation. When you hear stigmatizing conversations among your people, interrupt. And then I think also to try to advocate for some of this broader legal change in the environment in the state in which you live. If you live in a place where, like Georgia, where we are, that has that, that's something that needs to be shifted.
Yes, thank you so much, Justin. I love those takeaways that you provided for people, because I think that's one thing we need. Like, what can people do to, really work on the individual level and community level more broadly? And so for both of you guys, as Black people working in this space and health advocacy, like, how do you see how race impacts health outcomes, and how does that help you navigate the work that you do?
For me, I see it directly as a health literacy challenge, because you can tell anyone anything when they don't know. And if you're a provider and you're choosing to tell them disqualifying information, like it's been told historically for Black and brown patients who have inflammatory bowel disease, which is why it's diagnosed in such a severe state that they don't have this, they don't qualify for this disease because they're Black, it is reckless and endangering treatment. You're completely putting me out of a space to achieve wellness. And that's not, the oath is what? First, do no harm. You harmed me. It should not have taken me as a woman of color 20 plus years to finally get a diagnosis and to find support and comfort. No one should be living with a chronic stomach ache and not get help for it. And that's something that we all should know as people of color. There's something wrong. And we have to engage with Justin or myself, these community leaders, with Black Health, like you all, Marcella, to get more insight. Because if you're not properly diagnosed, you don't understand what's being told to you, then you aren't properly being diagnosed. So providers have to shift their language, because it's set to not have a point of entry for those with lower socioeconomic statuses. You don't have a point of entry when you're hearing someone talk about this. Even when you're educated, you don't understand health conversation and dialogue. So that's a part of the structure of racism, like to intentionally disqualify us to get what we need to understand what we're going through. And I see that every day and what people are being told. I had one gentleman, he's 20 years old. He just told me that his doctor told him that he couldn't, prescribe him a particular medication, because I said, oh, this is what your disease is presented. Why isn't your gastro providing you with this medication? He says, I have to see a specialist. He can't provide me with that. I told the manufacturer of this particular drug, because I said, what in the world? And the manufacturer said, what is he talking about? He's a gastro. Gastros provide these drugs. I said, I know this, you know this, but look at what this 20-year-old Black male who's suffering every single day, who had 5 things that he could eat that were making him feel better, but now 2 of those things don't work. So he's left to eat 3 things a day so that he does not completely go chaotic and poop on himself. I had someone told, hey, I understand that you're using the bathroom all day long. We can't give you disability, so just find a job that will allow you to work closer to the lavatory. From SSDI. So these are things that I think are heavily predicated on racism. So I see it every day, still today in 2021.
Yeah, just to kind of add on to that, I think oftentimes in the HIV space, we see a similar kind of challenge with providers not actually serving as the porters of health that they should be. So when we think about kind of the PrEP space, what I hear from a lot of young Black gay men that could benefit from being on PrEP, and also from cisgender heterosexual Black women, that conversation is not something that even comes up with their doctors, right? And so there's a sense that the providers really are serving as barriers rather than sort of points of access. in terms of who they think could benefit from these interventions that we know can be life-saving. So I think, the provider community certainly has to be, educated. I think, education is certainly a big piece of how we address some of these larger challenges. But I think it's also about how do we design systems such that they don't they don't allow for these kind of individual bad actors to sort of get away with it, right? So like in the story that you offered, Melodie, like there should be some consequences for that provider for not providing optimal care, right? So, I think we have to think about also what are the systems that we can design that can be responsive when folks are, having those experiences of discrimination, because oftentimes these are patterns. These are not sort of one-off types of situations. And we know that that's how racism functions. It's a system, right? So these are, systemic issues, and they have to be addressed in kind.
No, absolutely, Justin. And I was going to say also, when it comes to the LGBTQ plus community, a lot of providers are making patients who have IBD feel like, oh, you brought this on yourself. When we know that IBD is not caused by any sexual interaction, neither is CRC. So it's important for people. That's another stigma that prevents people from even getting in front of providers, getting the care they need. You need to get to your provider. It's nothing you caused yourself. And that's something that we always try to make sure we convey to our community. Remove that shift, remove that layer. You didn't do this. And now let's work to get your improvement. So there's that space.
Yes, absolutely. And it's really unfortunate because, again, like you said, the physicians, these are people that are supposed to be the ones to help you. And oftentimes they create more barriers than what already existed. And so recently the recommended screening age for CRC was lowered to 45, which was a huge win for many advocates, because through early screening and early detection, we know that we can save many lives. So could you both just talk a little bit more about how you are promoting screening and other preventative services with your work?
For us, a lot of our patients never even knew that CRC was a comorbidity. So we started with just presenting the information, introducing the conversation, asking them, has your care provider had this conversation with you? Have they told you? Because what they tell you usually about IBD is that it's not fatal. There's no detrimental challenges to that. And I said, that's great. I said, because CRC is not fatal, it can be preventable, treatable, all of that kind of stuff. Curable. I said, but you have to know that this exists, or you will ignore the more severe presentations of your disease, or you will, say, I'll pass this yearly checkup and go to another one. But in 2 years or 3 years, especially because of COVID, we've had a lot of community members delay their care. So we've had to introduce, this is the perfect time for us to have introduced this conversation, because it's triggered them not to be as lax with their care, because they're now getting information that I might not see it, but getting that colonoscopy, I've been screened early because I have different varying challenges with my Crohn's. And because of that, I get screened. My doctor screened. They're on top of that. They don't even tell me that they're doing it, because they already know that I'm going to ask, so they do it. But you have to get these screenings, especially when you're battling something that's directly in this gastro tract. So we present the conversation as just first a trigger to get them going, think provocative conversation, and then we educate on that. At our upcoming symposium that's on September 19th, we actually will be having some support from you guys there, and we will be having some fit kits so that the members who have not taken that step, they can start at home, which is just a lot more comforting than going to a provider. And we want them to be comfortable with this, because the better they process doing this, the more likely they'll get it done, as opposed to going to the doctor, setting up the appointment, drinking that soup prep or whatever you have to drink, and then going through the process. So we try to make it as inviting, as inviting as it can be.
Yeah, and I think in terms of HIV screening, we kind of think about the HIV test itself as really a portal to possibility. And what I mean by that is that no matter the results of one's HIV test, there's action that we can take. So if you take an HIV test and your test result comes back negative, what that means is that there's a whole suite of services that we can offer you that can help you remain negative. So, earlier in the talk, I mentioned PrEP, or pre-exposure prophylaxis, which is a daily medication you can take that is, pretty much, 99% effective at preventing HIV acquisition if you were to come in contact with HIV. So that's a really great tool that we can provide for folks that come in and receive an HIV negative test result. If someone takes an HIV test and their test result comes back positive and they find that they are living with HIV, that also kind of leads us to a whole suite of services that we can offer to make sure that folks can have the healthy life that they deserve, right? So, and that opens up all of the possibility of HIV care and treatment. And that includes, sort of the medications, but also there's a whole sort of suite of wraparound services we can offer for folks. People need help with housing, with, other types of kind of social needs. We can do that within our system. So, there's this notion of status neutrality. So no matter what happens with the result of your HIV test, there's something that we can do to support you. And so that's the message that we want to give to folks. And now we have, lots of different ways that folks can get tested. I think with the advent of the COVID-19 pandemic, we've really been trying to ramp up ways for people to do self-testing. So, I was talking to a friend the other day. It's like I have my whole self-testing clinic at home. I have my rapid COVID test, my rapid HIV test, and these are all things that you can, get over the counter. Also, in the notes, we'll provide a link if you're interested in getting, free HIV test kits mailed to you. There's several programs, including one in my agency and also one from the CDC that you can do, that you can get a free HIV test kit for yourself and also for a friend. So that's a great way to learn your HIV status in the privacy of your own home or wherever you choose to test.
Yes, I love that. And I think, I've had conversations with people, and oftentimes there's this huge hesitancy around getting screened for diseases just because it's well, I feel fine and I don't want to know because that's going to change things. And I'm well, if you have it, you have it, regardless of whether or not you know. So I think it's really great that you touched on just the importance of finding out your status and finding out these things through screening, because once you know, then you can take action on what to do next versus just sitting in the dark. And great point with the COVID thing. I too have a whole self-testing kits here. I have the FIT test, I have rapid HIV tests, COVID tests, all the tests, because I just like to know things. I'm that person. So knowledge is definitely power for me. And so, Justin, just a quick question for you also, just to follow up a little bit about what you were talking about. So we know that people with HIV are at higher risk for cancer and polyps, which can be precursors to CRC, than HIV negative individuals. Could you just talk a little bit about the importance of people with HIV just being advocates for their own healthcare and also just staying in care?
Sure. So, I think one of the things that is so important for folks to know is that if you're someone who's living with HIV and you are able to access medication and achieve what we call viral suppression, and that's the goal of HIV therapy, is to basically decrease the level of the HIV virus in your bloodstream such that it's not detectable on test. And that has benefits for you as an individual because that essentially reduces the amount of damage that HIV does to your body. So from a kind of personal health standpoint, that is really, wonderful because it really makes sure that you have kind of a very high quality of life. So from an individual level, that is really, really important. From a public health standpoint, what we also know is that if people are on HIV therapy and reach the undetectable status, they cannot pass HIV on to other people. So that's a great way to make sure that your partners also remain HIV negative if they are negative. So we call that, undetectable equals untransmittable, or U equals U. And I think, that also ties back to what we're saying about stigma, right? If more people knew that if someone's living with HIV and they're undetectable, they cannot transmit the HIV virus to someone else, there's no reason to have that fear and that concern, right? And so, because really at the root of stigma is fear, right? And so here's something that we know can kind of address some of that fear. And, one of the things that was most ignorant about the baby's comments was that, he said something about well, this disease will kill you in 2 to 3 weeks, which is totally not the case, right? And it's unfortunate that even in the year of our Lord 2021, there are folks that are still walking around thinking that HIV is a death sentence, and it isn't. And so I think, in terms of people maintaining their care, it's really about making sure that they have the highest quality of life that they can. And also, from the standpoint of public health, and make sure that, they're not able to, kind of transmit HIV to other folks, and make sure that they keep the ones that they love safe and healthy, which I know that is the goal. I haven't met anyone that is living with HIV that is like, ooh, let me go and give HIV to someone else, which I think is implicit in some of the laws that we have that I talked about earlier. Everyone has that kind of boogeyman story about like, oh, I heard somebody was trying to go out here and give HIV to other people, like that is not true, right? And so I think, making sure that people are able to be healthy both for themselves, also to protect the ones they love is so important. I think the last thing I'll say on this is that it's not just up to the individual patient or the person who's living with HIV to really advocate for themselves, although that is very important. I think we also have to think about how do we design our systems that are available to take care of people living with HIV such that they're actually responsive to the needs of the patient, right? And so I think what's something that unites kind of the experience that Melodie was talking about and the experience of people living with HIV is that these systems are not actually designed with the folks who are living with the conditions in mind. And that's something that has to shift because, this is designed to be something that's helpful. And, I feel like I hear so many horror stories of folks trying to get connected to HIV care and the barriers that are there. And the system exists for you, right? So, and that really invites the question of like, if it's not something that is accessible, if it's not something that folks are able to actually use, is this system the right system, right? So I think we have to begin to also ask ourselves those types of questions, even as we sort of think about the broader framework of kind of this disjointed United States healthcare system, in quotes, right? I think that's a broader battle, but I think that's also something we have to think about because, something that unites HIV, Crohn's disease, and all the other types of chronic diseases that we know that really in their social roots, a lot of those things come from the same place. So, we have to sort of address those underlying conditions, and that will have benefits across the spectrum of health and disease.
Yes, absolutely, Justin. I love how you just tied all that together, put a nice little bow on it. That was perfect. Because we are unfortunately out of time. And this was a really great conversation. I thank you both so much for your valuable insight, and Melodie for sharing your story. I think your story will help so many people listening to this conversation. So Justin, for you too, sharing that information because people don't know what they don't know, So I think that just having this knowledge that you've both shared today has just been awesome. And so before you all step off the stage, I just want you guys to plug your organizations really quickly, let people know how they can get in contact with you and support you in the work that you all are doing.
So you can follow us, Color of Crohn's and Chronic Illness, on Facebook. We also have Instagram, which is @ColorOfCCI, and Twitter @ColorOfCCI. If you are in need of any support, please email us at info@COCCI, which is COCCI.org. We look forward to supporting you.
And for us, you can find us on the web at positiveimpacthealthcenters.org. So I would invite you to check out our website. We also do have a Facebook page, Positive Impact Health Centers on Facebook, and then on Instagram @PIHC_Atlanta, and also that same handle on Twitter. And we'll drop that in the links later.
Awesome. Thank you both so much. Hey, thank you all. Thank you again to our awesome presenters. That was such a great conversation. And again, we want you guys to stay in touch with Justin and Melodie. So we'll be sure to provide you all with links to their websites, their emails, so you can get in touch with them. And then also for you all to get screened, if you are looking for an at-home testing kit, you can visit blackhealth.com, BLKHLTH. If you are in any of our ambassador cities, Detroit, Houston, Los Angeles, Oakland, Philadelphia, or Washington, D.C., please get in touch with our ambassador organizations to get you a screening kit, as well as reach out to our friends at the Colorectal Cancer Alliance. Again, you can reach out to these places and get free screening kits. You do them in the comfort of your home. You don't have to send anything off into the mail. You get your results at home. And if you need any follow-up care, any resources, we will be happy to connect you as well. Again, visit our website at www.blackhealth.com to just learn more about colorectal cancer and any resources. Again, if you need any financial assistance, if you do get a positive screening, you can reach out to our friends at the Colorectal Cancer Alliance and get some financial assistance through our Good Down There Fund. Thank you all again for tuning in tonight. I hope you guys really enjoyed this conversation. If you want to get in touch with Black Health, please follow us on social media. We are on Instagram, Twitter, Facebook, LinkedIn. We're everywhere. There's our email, engage@blackhealth.com.